I am going to have the pleasure of introducing some of my dearest colleagues, and I'm going to focus first on Linda Hauser, who is my NP partner, has been with the center for over 13 years, and really is the heart and soul of so many of our staff and our patients. And she is going to talk about exercise. Lifestyle considerations. We gave her a mouthful of a topic, and I apologize to her, but she, like always, has done a stellar job in putting together some thoughts. Lifestyle considerations in adult congenital heart disease, exercise quantification, and defining normal. Thank you, Linda.
Thank you, Pam, and good morning, everyone. I have nothing to disclose. And I'd like to start off with a clinical encounter. A 40-year-old patient with a history of tetralogy of Fallot who's undergone surgical repair in childhood presents to your clinic to establish care. He doesn't recall much about his early surgeries, but he does know that he was followed for most of his childhood and into young adulthood by a pediatric cardiologist. But after college, he was lost to cardiology follow-up and really hasn't been back to see a cardiologist for the past 2 decades. From a cardiac standpoint, fortunately, he's been relatively asymptomatic. He has no particular health concerns, but when you ask him about exercise, he does admit that he's led a very sedentary lifestyle. He works in an office job. He really doesn't get very much exercise at all, except for maybe playing with his kids on the weekends. And he's gained about 20 pounds over the last decade. And so his wife and his kids and his primary care physician, who sent him back to you to reestablish cardiology care, have been after him to lose weight and get in shape. And he certainly agrees with this, but he is a bit anxious. He recalls being told at some point along the line that exercise could be dangerous for him, and he recalls being kept out of competitive sports and PE as a child. So he needs your guidance. You send him off for an exercise test, and he manages to go 6.5 minutes on a Bruce protocol and achieves a VO2 max of 20.3 milliliters per kilogram. He had no significant arrhythmias, and his echocardiogram showed appropriate ventricular contractile response and moderate pulmonic stenosis and regurgitation with exercise. So he'll be back in a week to sit down with you and talk about your recommendations and further management. I use this case to demonstrate and to illustrate the point that knowledge of functional capacity and exercise ability are core components of ACHD care. This knowledge of functional capacity, and especially how this changes over time, allows us to determine the need for and timing of things like interventional procedures and cardiac catheterizations, EP procedures such as pacemaker placement, ablations, or ICDs, whether to send a patient back for a surgical procedure. It also helps us to fine-tune medication management, to advise families on family planning and risk stratification for pregnancy, to have realistic conversations with our patients about lifestyle and career choices, and finally, of course, to develop and furnish appropriate exercise prescriptions. But defining normal across this very diverse, heterogeneous population is somewhat of a challenge. Our patient had tetralogy of Fallot that was repaired. But exercise capacity can vary greatly across the spectrum of these ACHD diagnoses and all of the procedures and surgeries associated with these diagnoses. And now, if we add in additional elements of residual lesions, medications, arrhythmias, extracardiac organ involvement, cyanosis or pulmonary hypertension and developmental delay, defining normal, it is clear, is not a one-size-fits-all approach. But the process of exercise quantification begins quite simply one-on-one in the exam room. Each patient needs to be asked in detail about their exercise abilities, how much they're doing, how much can they do, for how long and how many times a week are they exercising. And more importantly, how has anything changed, positively or negatively, since the last visit? We need to do a little bit of digging here sometimes because this is subject to patient recall, and patients sometimes have a tendency to under or overestimate their own exercise ability. So to be able to provide appropriate exercise counseling, we need to be fairly specific. Activity trackers, these wearable devices, Garmins and Fitbits, are another way of objective patient self-quantification. These devices track physical activity throughout the day. They track our 10,000 steps or so. Not only steps, but intensity of steps and intensity of exercise. They even track sleep activity. And this information can be downloaded onto their smartphones and reviewed with you in clinic to hopefully set goals for the next patient visit and to increase their motivation to exercise. 6-minute walk testing is another very useful objective test of functional capacity that we can readily obtain in clinic. This is a particularly useful test for our Eisenmenger patients, not only in assessing their functional capacity, but evaluating their response to therapies such as pulmonary vasodilators on a clinic-to-clinic basis. And finally, cardiopulmonary exercise testing is, of course, a key test that we rely on very heavily. Most, if not all, of our patients undergo at least one cardiopulmonary exercise test, and most quite a few more. Decidedly to mixed reviews and levels of acceptance. But it is a very important test, very valuable. It is non-invasive, and it provides objective, precise, and reproducible assessment of a patient's functional capacity. Unlike conventional stress testing, which typically assesses mainly for ischemia, which is not typically a cause of symptoms or exercise intolerance in our patient population, CPET provides insight not only into cardiac physiology, but also into pulmonary, musculoskeletal, and other systems responsible for the body's integrated response to exercise. And importantly, certain CPET parameters have been associated with survival, particularly peak VO2, or maximum oxygen uptake, ventilation to CO2 production, or the V to VCO2 slope, and heart rate reserve, the difference between maximum heart rate and resting heart rate. So to the extent that we can improve these parameters, either with exercise or with some of the other measures, surgical, electrophysiological, or interventional, I think the better long-term outcomes we can offer our patients. Now, multiple studies have demonstrated that kind of across the board, throughout, from simple to complex lesions, exercise capacity in adults with congenital heart disease is less than less compared to the general population. And so comparing cardiopulmonary exercise data of ACHD patients to standards developed for the general population for diagnostic and counseling purposes may be less useful than trying to compare these patients within their own cohort. And this study by Kempney that was published in 2012 from the Brompton Hospital in London allowed us to do pretty much just that, or helped us to do so. The group looked at exercise data from a large sample of ACHD patients, half of which came from their own institution and half from the literature, just about 4,400 patients in all. And using this data, they were able to develop age, gender, and diagnosis-specific reference values for exercise capacity across a wide range of ACHD diagnoses, as seen here. So it should come as no surprise that the patients with the lowest functional capacity were those with complex congenital heart disease and Eisenmenger syndrome, with the highest values going to patients who've undergone the arterial switch procedure for transposition in the neonatal period, with the rest of the diagnoses falling in between. And having this data allows us to interpret CPET testing on our ACHD patients on more of a uniform playing field. For example, we can tell our patient in the opening case study that his VO2 max of 20.3 puts him in the lower end of his tetralogy cohort, but we can then work with him to develop a plan to optimize this number as best as possible. We know that many of our patients with congenital heart disease do exercise on a regular basis, some at a highly competitive level, others even at an Olympic level. But we also know that a substantial portion of them do not. And with the adult congenital population approaching 1.5 million in this country, that implies a substantial portion of our patients who are putting themselves at risk for the consequences of a sedentary lifestyle. And this apart from any issues related to their congenital heart disease. And while we're taking care of their heart disease, we need to be monitoring them for these types of secondary consequences, which we know that exercise can in some way mitigate. But as we heard from our patient in the case study, a part of the reason that patients do not want to exercise is that many of them have been given the message somewhere at some point that exercise may be unsafe. I find this to be true in a lot of our older patients. This message might have come from their families, or maybe even a well-meaning doctor who simply wanted to protect him or her in the face of insufficient evidence on the safety of exercise. And so as adults, when these patients finally are told that they are allowed to exercise, many of them need a bit more support and reassurance. So I think we ought to be able to reassure ourselves that exercise in ACHD is relatively safe, and I think most of the data that's coming out, for the most part, has been very positive. This literature review by Dupin looked at a number of studies investigating exercise programs for either positive or negative effects of exercise. And the data was actually very good. 72% of the studies showed a positive change in the parameters of VO2 max, which is illustrated on this chart up here in the open-celled circles, exercise activity level, and muscle strength. Some studies showed no significant difference, but importantly, none of the studies showed any negative findings. Now, does this mean that exercise in adult congenital heart disease is without risk? Of course not. And does this mean that we don't need more studies? No, we actually probably need a lot more studies in our older patients with congenital heart disease. But I think from what we have now and from the literature, we can pretty much reassure our patients that exercise, as long as you are thoroughly evaluated and followed up, can certainly be enjoyed, all the physical and the psychological benefits of exercise. This study that came out of Boston actually shows the further benefits of exercise and why it's important to sustain an exercise program over time. These people looked at exercise data across a 6 to 24 month period on a select cross-sectional group of ACHD patients. And they found that patients who engaged in, they call moderately strenuous activity for at least 2 times a week, not only increased their VO2 max as we would expect, but they were able to sustain this level over time. And so this implies that the time-related decline in aerobic capacity that's frequently reported in longitudinal studies may be modifiable. So this is another reason to continue to encourage our patients who may be inclined to wonder why they need to keep exercising of this benefit. So now that we're at the starting line and ready to send our athletes out onto the course, let's first just exercise a few words of caution. Patients who are exhibiting malignant arrhythmias, particularly dangerous ventricular arrhythmias, new exertional symptoms that you don't really have a good handle on yet, unaddressed lesions, and patients in decompensated heart failure who, I venture to say, probably wouldn't want to exercise anyway, but should all be worked up and cleared before being released and addressed before being released to participate in exercise. So now we return to our UCLA ACHDC clinic. And our advice for patients is to try and get, at a minimum, oh, my screen's back. Oh. At a minimum, 30 minutes of physical activity a day. This doesn't have to be a dedicated exercise period, but trying to get at least 30 minutes of combined activity, and either by parking your car away from your building and walking a little bit farther, by taking the stairs for a few flights instead of the elevator, by taking a short walk during your lunch break or any time you have time during the day for 5 or 10 minutes. All of this adds up and counts. For formal exercise, we advise our patients to participate in at least 30 minutes of low to moderate aerobic activity for at least 3 to 5 times a week, and increasing that as they can to most days of the week. This can include elliptical training, swimming, running, jogging, yoga, whatever they enjoy and feel like they can continue to participate in on a regular basis. That is what we would like them to try and stick with. Isometric weight training is also acceptable, provided patients can do 10 to 15 reps of a given weight comfortably without straining, breath holding, or grunting. This also holds true for exercises using your own body resistance, such as pull-ups or push-ups. But please don't let me catch you doing anything like this. We really discourage competitive bodybuilding, powerlifting, or exercising to muscle failure because of the dangerously high intra-aortic and intracardiac pressures that can be generated with these types of activities. And these pieces of advice that we give to patients are pretty self-explanatory. So just to wrap it up with final thoughts, we need to be discussing exercise and physical activity at every visit. With very few exceptions, most of our patients can safely participate in some degree of physical exercise. We need to recognize that there is not one normal, there are many normals, and we need to find in this heterogeneous population the baseline for every patient that determines their normal, and work with them to optimize it to the extent that we can. And we need to continue to reassess these patients regularly. Thanks very much for your attention, and enjoy the rest of the conference.